You see the cuts are healthy, no big problems here. But on the other side, pay attention please, everything's flattened. Everything's flattened. When we look at lower jaw, here, right side, everything's healthy, but left side we have some problems. Why is that? Why left side is not really healthy and right side is healthy? This opened the question for us. So every case comes to you when you see that somewhere posterior there is no cusp, everything is flat, and you should ask yourself, how is the movement of the lower jaw that the abrasion and tooth wear is so much posterior? It means there is a lot of movement, not normal movement. Again, look. It means lower jaw is moving a lot. There is interference between these two. Something is broken. Why? Before we are going to fix it. So the videos are very important because we can see the movement of patient, how she speaks, how she laughs, all this information before we do the DST. Of course, close up, taking information, the lip dynamic. Look at here. Fortunately, it was a vertical chewer, which gives us a lot of space. If she was a horizontal chewer, it was totally different. So it gave us a little bit of space to work easier in the case. So that way, important RSP, X-rays, and CBCT scan in order to get all the information and put it in your tree shape or exocad. In this case, we work with the exocad to work with. Look at the condyle head of the right side and left side. We don't see the condyle. Where is it? Look at here, beautiful pictures. Right side, very healthy glenoid fossa, very healthy condyle head, nice corners. But the right side, left side, we see the flattening. There is flattening, so it means the lower jaw moves differently. You go closer, we make pictures, we can measure everything. You would ask yourself, how do you measure it? Because I give the information to exocad, and exocad can measure everything for me. So we see the anatomy of the right side is different than left side. So it means the occlusion which you are going to create should be different at the right side and left side. Otherwise, you will have a problem. You will face the same problem as before. So all the information, CBCT scan, all goes to the exocad. We will measure everything and make a picture of this. Is very important. As a technician, you have to have some basic knowledge of the size, anatomy, and condition of the condyle head. Very important. Because if the condyle head is small, the range of movement will be more, so your occlusion will be different. If the head of condyle is small and the fossa is like that, the movement will be again different. So we measure the left side and right side. Left side is 16.0, right side 16.8. We go further, 16, 12, loss, 4 millimeters. 4 millimeters loss of the anatomy of the condyle means somewhere smaller or bigger occlusion. We will find it out. So some movies, not for today. And now the concept changed. We need CR and also fully seated condyle position. You have to determine it. Now we know why the dentist was not able to find the right place of surgery at the first moment. So that way for us as technicians is also important to understand anatomy, condition of the muscles and bones. So the occlusion is not the teeth, this is the occlusion. So we have to know this before we start the design of anything, any case. And the ramus. A natural ramus, a healthy ramus has a length between 60 and 75. Should be always the same? No. But what's important, we should see symmetry in the ramus. Very important. Our studies and literature. Good, we have now information. You see what is the effect of the normal ramus, what does the long ramus to the face, to the facial appearance, and also to the dental appearance. Long ramus, we measure the head of the condyle to the angle of mandible. And this is the size, the length of the ramus. So you would say this is not really very important, but we can, when we look at the studies of Dr. Frank Spear, we will see the bite changed. The bite changed because of the length and the form of the ramus. Look at the normal ramus. You see a nice lady. Why is she nice? Why she looks nice? Because the proportions are healthy. This lady is also pretty, but you see very long ramus, so the face becomes more square. This lady, also very beautiful. Short ramus. All three are beautiful, but you see the appearance of the face is different. And when we look at the mouth, short ramus and long ramus. So if the dentist sends the pictures without face, you don't know which kind of case are you dealing with. So facial pictures and retractors are very important. Good. Imagine the length of the ramus. Back. Right side 63 millimeters, right side, left side 58. So very short. So we have flattening, short ramus. It means lower jaw moves a lot. That's why occlusion of the left side is damaged. So now we know the cause, and now we have to solve it. So very important picture. In every case, actually, you have to have this picture to see what is the, what is the length of the ramus, what's the length of the eminence to the distal part of the first premolar. You see the left side is shorter, so left side is totally shorter, it's smaller. Good, now I have the information. Now I go back to the aesthetic. I create aesthetic in order to design the wax up, and then we have to change the wax up to provisionals and go ahead and finish the case. So, these kind of pictures are very important. If you work totally digital with face hunter or face scanners, you can use the glass of digital dentistry. The rest is very simple. Some DST lines, intraoral pictures, project onto the extraoral pictures. Now we don't need the face, and now we see the differences. Left side is shorter, smaller. Now we know everything, yes? It's not just guessing. We should understand it. Put the golden proportion, or Preston proportion, whatever, and we see there is no harmony, there is nothing. No symmetry, no harmony, and we can't make any orthodontic treatment, we can't open the maxilla. This is it. We have to fix it like this. Good. This is the design, and I use also the smile cloud to create some nice smile to show it to her. And we thought, okay, this is good start. We are going to following this path and see if it works in the mouth. And I have to tell you, the first mock-up maybe is good. If your first mock-up is good, you are very lucky. Your dentist is lucky, and your patient is lucky. Because when the mock-ups go in the mouth, you have to check all the phonetic and all the movements. And in this case, we found out that the first mock-up and the second mock-up and the third mock-up was not good. We needed to customize it and to change it. So, this digitally, we need the dentofacial coils analyzer because I wanted to make it sure, they're all studies, the distance between the condyle head, the rotational movement, and the central incisors is about 10 centimeters. There are studies, so that way we need the right position of the maxilla into the articulator to put in the digital dentistry and go ahead. So they're all information which we need. So here's Dr. Bernard busy to define the position of the upper jaw related to the eyes. So, and wow, this is wow, because when you work with digital dentistry, you can see the curve, the sagittal curve is hanging. This is not healthy. Beautiful curve should be straight, or we have to have the positive curve. And now we have negative curve. It means we need a lot of orthodontic intrusion to come on the top of the triangle. We can't. We cannot do any orthodontic treatment, so we need to do it restoratively. It means we have to open the bite. She can't prep everything. It becomes, when you have knowledge, you see everything becomes more and more complex because you have to fix it. So now we have to change our strategy in order to making the wax up. So I open the bite to start somewhere, about 2 millimeters. I made the first wax up, and I give freedom to the lateral pterygoid muscle. You see here, the lower jaw can go easier out. So when we have a deep bite, it's very difficult for lateral pterygoid come here, come out. So when we procline the upper jaw and lower jaw and make the bite open, it's easier for the muscles to move the lower jaw. So we have to give comfort. So this is the first wax up. It went to the mouth of patient. Here is called Edris, the teeth are too big. You should make them smaller, okay? The angle is very important. So, I made the second wax up. Now she told me I see too much of the lower teeth. It doesn't look nice in her face because she has a big display. So we need now to stay in the aesthetic, stay in the function, and create something nice. So I made the centrals again smaller. I made end-to-end. It was also not good. So we were playing with the wax up until we had the right design. So the first one, second one, and the third one. Now I give the information where she needs to grind. This is also very nice to communicate digitally with your dentist in order to grind it. So we are going now restoratively to expand the upper jaw, give more space. Some videos, she sent me some videos because the patient didn't come every time to me. We see a lot of lower incisors. So we need to shorten them. So we let patient count from 60 to 70. And now I do the final adjustment. I open the bite. Posteriors, I keep it as small, as close as possible. And I do the wax up digitally. And I love these pictures because you can cut it through. You can see how is the freedom. So the final design. And now she can grind down and prep everything. So before we start grinding, we were thinking and calculating and doing the wax up and the mock-ups. So that's why we call it diagnostic wax up and mock-up. So, intercostal position in no case is perfect because this is a skeletal problem. So we have to deal with it. So we know the lower jaw moves backward and to the left a lot. So I have to take care of that. I have to give freedom to it. So here we see the inferior head of lateral tailbone muscle. Look how the movement is. So we can put all this information to the exocad in this case. So right side, 35 degrees, count line, slope, and 15 degrees bended shift. Bended angle, sorry. And when we go to lateral occlusion, you see I give a lot of freedom. 15 to 20 degrees. This is 90 degrees, this is 45 degrees, this is 15 degrees. So a lot of freedom. And we are going to test drive it by using the provisionals. Otherwise, this is just a theory. We should test it in the mouth. The most important picture of the day today, guys. Because this makes sure your restoration go for another 20 years. So, and the study is very cool. The study is from 1989, very old. So there are all this information out there. We can put some terminology in it, lateral protrusion, protrusion, mid-protrusion. We learn it all at the school, but we are not going to use it. We have to use it. Good. We make a video of it. We have the static occlusion. This is static occlusion. We ask patient to move to the left and right digitally. Disclusion, canine guidance, very important, in order to decrease the muscle activities. Back to the static occlusion. And now to the other side. Comfortable. We go back to the static occlusion, and then we have the proval movement. So, now we took care of early side shift, immediate side shift, progressive side shift, static occlusion, dynamic occlusion, and anterior guidance. Very important. If we miss one of those, we will see the problem after some months. Something come off, something break off, something cracks, and this is what we don't want. So now, dentists can go ahead and remove all the old restorations. So it was very exciting for us, because finally we have the plan. Finally we have the plan. She grind the old veneers and crowns, and we create by using multi-stratum circumscan, we provide the multi-stratum and provisionals to test drive it. And went to the mouth, and she said for the first time, it's strange, but now I can feel my mouth. I can feel that I have every contact. We asked her, is it comfortable? She said yes. She needed to grind a little bit here and there to create the comfort in the mouth. And she said, I feel good. So we can now check the aesthetics and also evaluate the function in the mouth. So they are provisionals. As you see at the right side, because we have here the centric, I didn't create extreme overjet. But at the other side, I gave more space. I create more overjet because I want to give freedom. I don't want to have any interferences with the muscles. The muscles should work as they are. We can't change the muscles. Good. Occlusal view. Left and right. Test drive 3 months. Everything was intact. Nothing came off. Nothing was broken. So it means occlusion is good. So now we go ahead and finish upper jaw. We always start with upper jaw because it's fixed to the skull. Upper jaw. So I take the bite registration. This is the evaluation of aesthetic, left and right. Temporaries. This is the right side of the mouth. Overjet. So expansion and a little bit proclination to give more space. Lower stays in the provisionals and upper I go to Emax. I do the labial reduced technique or the biomimetic layering technique, which I demonstrated yesterday. So I do use the internal stain technique, and then on the top I use some ceramics. I bake it, mechanical polishing, a lot of work. Everything is ready. Patient comes to me, dentist came to me. We tried it in and went to the mouth, and she's going to bond it. So bonding on the right way takes her per tooth about 20-25 minutes. So a lot of work. Hours of work. So the lower jaw we always do in 3 segments. We start with the most difficult segment, and then 1 month later the other segment for posteriors, and later on, or the last one is anteriors. Because we want to take out all of the biological and mechanical problems out of the system. So it's still because the condition of the canal on the left side was not good, we were using the genatological wax. This is wax which you can put in the mouth. It comes actually from Germany, but nobody uses it because everybody believes they know the occlusion. No, this is a very, very good material. Unfortunately, we can't find it, so I created myself. This is wax which goes to the mouth, and by body temperature becomes softer. And patient can chew on it in the natural head position. So patient comes to the office, dentist put everything in the mouth, patient sit down and start chewing on it. And we give also some chewing gum to the patient. It looked like that. And so, don't be careful, just go ahead and create the customized occlusion pattern. That is the best way, there is no other way. So, now, she created the best occlusion what she has. Now, the surface of the wax is holy. I don't change it. I just clean it, I make it nice. I press it by lithium disilicate, LT bleach 2, because she wanted, of course, to have bleach. Everybody wants bleach. I just make it a little bit nice and then bond it. So I use the digital technology. I create the crowns because this wax is expensive and I don't have much. So I just wanted to use it efficiently. So we create new occlusion. It doesn't need to be beautiful. It goes to the mouth. And the same, patients start chewing on it. So when you see that everything is intact, everything doesn't come off or breaks, and everything is comfortable, that you know your work is good. And if you find some mistakes here, you're fixing it. You don't go directly to ceramics. Good. Again, come back to me, clean it, press it, glaze it, mechanically polishing, and 4 weeks later, patient come back to me. I finished anteriors. So a lot of hours, a lot of work, but systematic, step by step, slow dentistry. So we started here And we finished here 28 restorations, LT bleach 2, facial, layered, and the rest is only monolithic and staining technique, mechanical polishing. So we played a little bit with the form, we made the form a little bit more aggressive in order to don't have just white Hollywood, not beautiful teeth. So left side, the most critical part. So we have overjet, we have overbite, we have the function, we tested already. Right side was not very difficult. Intercostal position is nice, everything is intact. The gingiva is beautiful, everything is healthy. Of course, we lost a lot of gingiva, but it was what it was. And the smile. And then you will see that the face changed. If everything is right, you make people happy. Still a lot of range of motion. She has a lot of a bright smile. And she put on some makeup. You see, a woman should be beautiful and should be proud of her smile and her appearance. And it's wonderful to give it back to people. Not just aesthetic, but occlusion, function, lifestyle, healthy occlusion, to enjoy the food. So, and of course, the involvement with the dentist, the teamwork, to put the hours and effort together is very important. You need a team, it's like football. If your team players are not good, you are nobody. So try to work with good people, people with passion, with love, with knowledge, and support each other in order to make people happy. You have a beautiful job, you make people happy. So let's do it very well. So this is one of the cases which we did together, and I chose it because it was complex and I wanted to give you more insight because people know me as aesthetic technician, but behind aesthetic is all of this word to understand the bite and occlusion and the function and durability and longevity. So we are also affiliate of EAD, European Academy of Aesthetic Dentistry, so we are going to be also active members, so it means a lot of work. Conclusion, very important. CR, retruded contact position, and ICP, intercostal, are very important. We have to register both, because there is a shift in between. A dentist should take care of this information and provide it to us. We as technicians should take care of this information and put it in our work. There are many systems and many instruments to do the work right, so do it right.